Welcome, class. Units 8, 9, 10, and 11 are part of the cognitive rehab unit, and we will be looking at strategies for treatment of cognitive dysfunction. I want you to prepare for this by reading your material in the Maley book, the Zoltan book, and reviewing the PowerPoints and the videos that are on in the unit. Also, please take a look at AOTA's papers and their statement regarding cognition and the occupational therapist. So AOTA states that practitioners facilitate cognitive function and enhance occupational performance, self-efficacy, participation, and perceived quality of life. They also have cognition is necessary for the 8 areas of occupation and everyday tasks. OT practitioners are uniquely qualified for cognitive rehab, and engagement in desired occupations are central to cognitive intervention. So what are the mental functions? Information processing functions carried out by the brain. We have memory and executive functions and attention. What are our specific mental functions? They're the higher level cognitive function, such as judgment, concept formation, metacognition, or thinking about thinking, executive function, decision making, abstract thinking, planning, mental flexibility, praxis, which is sequencing, organizing, and initiation. Then there's cognitive flexibility or problem solving, shifting, thinking strategies. Does this all sound familiar? It should, because it's in your framework. Then there's also insight or self-awareness. What is attention? It can be sustained, it can shift, it can be divided, concentration, and distractibility are all forms of attention. What about memory? You have short-term memory, and that's where mental functions that produce a temporary disruptible memory store of around 30 seconds duration, from which information is lost if not consolidated into long-term memory. So short-term, 30 seconds. And you have your working memory. Your working memory is where mental functions that produce a memory system permitting the long-term storage of information from short-term memory, and both autobiographical memory for past events and semantic memory for language and facts. In other words, that's where your brain seems to be working the most for all the new stuff. And it's putting things together and preparing for the long-term memory, which is where information that is retained while we are using it during a task, temporary information that allows for manipulation of information. So we pull from our long-term memory to try and use it in our working memory. Then there's emotional areas of cognition, which requires regulation, and there's a range of those emotions. And there's appropriateness of emotions. So you've got anger, love, tension, anxiety, and lability. Experience of self and time. That's awareness of one's identity, body awareness, position in the reality of one's environment, and reality of one's time. So this is the experience of yourself in time. Then what are the global mental functions? Orientation, energy and drive, motivation. Now that we have a basic understanding of what the cognitive functions are, let's take a look at cognitive dysfunction. Cognitive dysfunction may occur across the lifespan. It may be transient or permanent. progressive or static, general or specific. Maybe a mild impairment or a severe impairment. Cognitive dysfunction may be associated with many different diagnoses, such as human genetics, such as fetal alcohol syndrome, neurological diseases, stroke, traumatic brain injury, mental illness, such as schizophrenia, and just generalized stress and change in the environment. Some examples of cognitive impairments include confusion, when the person responds to a simple question with an unrelated remark, or disorientation, such as the person says that the year is 2003. Inability to recognize objects or a person. A man may not recognize his wife. Reduced attention or inattention. The grade school student attends to the task for only 5 minutes during a math test. Or difficulty initiating an activity. The homemaker does not start dinner in time for an evening meal. Some other forms of cognitive impairments include difficulty ending an activity. The person with a brain injury brushes his teeth for 15 minutes. Or deficits in short-term or long-term memory. The client cannot remember where his or her wallet is and cannot remember when the wedding date was, which was the long-term memory. Inability to sequence logically. Client dons his shoes before his socks. Difficulty recognizing categories or placing objects in categories, such as when putting away groceries, client puts items into cabinets and refrigerator, not differentiating those that need refrigeration. And some more include difficulty organizing information or recognizing its significance. The client puts all the mail in a drawer, mixing advertisements with official notices, bills, and important correspondence. Has problems understanding how objects related in space. When asked to make a sandwich, the client puts 2 pieces of bread on top of the piece of cheese. Difficulty solving problems. Client tries to move foldable shopping cart through a narrow doorway but fails to fold it and turn it sideways, then abandons the task. Difficulty learning new information or skills. The client needs cueing and supervision to travel to a local pharmacy. Difficulty generalizing or transferring skills or knowledge from one situation to another similar one. The client can use a specific bus and route, but does not generalize this to other buses and routes. So now what do we do about this? So let's look more into some cognitive strategies for rehab. First, we have to make the assessment. And how do we do that? There are several ways to evaluate for cognitive function. First, you want to interview the client and others. You want to do a screening. There are performance-based assessments. There are some specific cognitive measures that can be evaluated. And there's also environmental assessments. So what are some screening tools we can use? Some of these you've known before in practice, such as the mini mental state, the short blast memory test, the Montreal Cognitive Assessment. You need to be familiar with these, and I would suggest reviewing these before you come to class. The Lotka, the Rancho Los Amigos scale, and the Allen Cognitive Level Screening are also screening tools. Then there are some performance-based assessments, such as the Executive Function Performance Test. These are assessments where the client has to demonstrate activities. The Assessment of Motor and Process Skills, you'll also know that as the AMPS. The Routine Task Inventory is another one. The Multiple Errands Test. Again, probably a good idea to take a look at these and see if you can familiarize yourself with just a general idea of what they are. And there's a Children's Kitchen Task Assessment as well. So measures of specific cognitive functions and client factors. We can even break down the deficit areas and evaluate specific deficit areas, such as if you're looking at memory, you can use a contextual memory test, the River-Mead behavioral memory test, a test of everyday attention, and a behavioral assessment of the dysexecutive syndrome. So notice these are client factors, and so specific assessments for each client factor if you know what the problem is that the client is having. Specific measures of cognitive performance in the context of specific occupations, such as the ADL checklist for neglect, the EFPT, the Executive Function Performance Test again, and the AMPS again. So these are more of the context. Where is the problem? Where are they having the problem? And then the environmental assessment. So you want to look at patient safety. So you're going to do a safety assessment of function and the environment for evaluation, or a home environmental assessment protocol. Maybe the patient's having trouble in the kitchen specifically, and they're at a safety risk. So you'd want to make sure that they can be safe in their house. And again, if you're not familiar with these, I would just take a look at them, look them up, and just have a general idea of what they are. So how do we approach cognitive rehab? We've heard of frames of reference, we know models of practice, but what do we use when we are working with the cognitive dysfunction? Well, there's several, and one that I particularly like is the dynamic interactional model. It gains more control over symptoms by efficiently and independently using strategies for information processing. We are working with the client to learn how to control their own cognitive dysfunction. There's a cognitive rehabilitation model of Katz and Averbach. It is more of a comprehensive approach, and it's enhanced to retain cognitive ability, development of self-awareness, uses remedial cognitive training strategies, targets specific cognitive areas, visual motor organization, thinking operations, visual perception, learning strategies. This is not one that I'm very familiar with, although it does have a very wide range of overview for cognitive dysfunction. It might be worth reviewing. And it does remedial basic activities of daily living strategies. Then there's the Allen's Cognitive Disabilities Model. I believe y'all have been through this in some of Miss Stanford's courses, or throughout your first year. So you should be familiar with how Allen uses this for dementia. It's been used for TBI, severe mental health disorders. It describes deficits in routine task behavior, predicts what a person will be able to do across multiple domains. It identifies assistance required, including safety and communication, provides appropriate teaching methods. And then there's the cognitive orientation to daily occupation performance. You should have heard this already as well. It's the co-op model, and this is used a lot for children with developmental coordination disorders. It's been used widely with neurological and adult populations. It is client-centered. It focuses on problem solving. It's performance-based. There's a guided discovery of strategies for learning skills. There's global strategies. And there's a general problem-solving approach or domain-specific. So you can approach this from several different ways. Then there's the neurofunctional approach. It's developed for TBIs, or traumatic brain injury clients. It's used with stroke victims and other neurological impairments. They have independent living goals, collaborative approach for goals, task analysis with constraint model. The collaborative approach means that it is used amongst all the different disciplines. There's an automatic behavioral routines, and those are foundational. Experiential individualized interventions. It is based on learning theory. Errorless learning is used in this approach. Self-generation, overlearning. This is very common with the TBI patient that has is probably at a stage 3, 4, 5 of the Rancho scale. Then there's some environmental models. There's a cognitive disabilities model, and that's understanding clients' needs for environmental support. A press competence model, which is the relationship between capacity and environmental attributes. Environmental skill building. So they assist the caregivers of dementia patients to adapt environments for safety and behavioral issues. So the environmental models are more adapting the environment than they are the abilities of the clients. So now that we've seen the approaches that we would take, and we know what cognition is and what cognitive dysfunction is, now what are we going to do about it? How are we going to fix it? And so there's different types of interventions. We have compensatory or adaptive interventions, and that provides structure and support to compensate for cognitive deficits. That's where the client learns to use a strategy, a task or environment is altered or adapted. And then there's remedial training, which is expanding on underlying skills and abilities and supports the reintegration of cognitive functions. So we're going to be looking at either compensating or remediating. And the remediating is not often used as they are time consuming and often ineffective. However, they can be used for some people. The global strategy learning and awareness approaches include where it assists clients to develop higher order compensatory approaches versus your basic remedial approaches. And it includes generalization to novel tasks, so they have to have some ability to learn. And there is a holistic analysis. Then you have some domain-specific strategies, which includes where they manage specific perceptual or cognitive deficits. Maybe they've only got one specific cognitive deficit, and so we're going to really focus in on that. Or they need social skills strategies for personal interactions. Maybe they just need a mental checklist for using personal digital assistants. Or just a routine scanning. We teach them just to routinely scan the environment to look for cues. Then there are some cognitive retraining that is embedded in functional activities, such as cognitive processes within the cognitive processes within context of the activity include generalization to other tasks, such as front buttoning a shirt to front closing a jacket for problem solving. Specific task training is when we circumvent the cognitive deficit. In other words, we're going to teach them this task and get around the problem that they're having. They will perform a specific functional behavior, and they may improve self-awareness and mental efficiency and organization. Errorless learning is included in this. They continue to repeat the task until they get it right. And routine learning. It's over and over and over learning the routines. Then there's the environmental modifications and uses of assistive technology, which addresses complexity of activity demands to clients' ability. You use memory strategies, task initiation tools or cues, structure and sequences of tasks, content of social network. So let's get to some specific interventions. Reality orientation. We use this to reinforce a client's sense of personal identity and awareness of time and space and place. It relies on clocks, calendars, and personal mementos. Remotivation helps depressed and confused clients verbalize thoughts and feelings in a group setting. Topics include client interests, hobbies, or past experiences. Using a computer. Basic tasks on the computer are easily mastered. So computer use can be for remediation, such as attention, and that type of thing, not necessarily adaptive. Games can provide a successful experience. And it can also provide feedback about performance. Computers feel educational rather than therapeutic for some people. Educational kinesiology uses complex body movements that cross the midline. So that would be like a brain gym type thing on the computer. So let's look at attention. Attention is a system that helps maintain a general state of readiness to respond. A system that sets the threshold for responding to an external stimulus. A system that helps with selectively attending to appropriate stimuli and inhibiting responses to competing stimuli. It provides occupation-based activities in either a restorative or adaptive approach related to the specific type of attention deficit. That is what we do when we are treating attention deficit problems. We want to provide occupation-based activities in either a restorative or adaptive approach according to the type of attention deficit. And you can review this further in your Zoltan book on page 202. Orientation. There's orientation to person, place, time, self, and others. And the interventions can include group or individual reality orientation, some external aids such as pictures, calendars, and clocks, organizing a daily routine, incorporate familiar objects from home. See pages 192 to 193 in your Zoltan book for more suggestions, and try to review this prior to class. So let's talk about memory. There's short-term memory, long-term memory, working memory. There's client-centered working memory, identifying the learning style, and using pictures. These are ways of working with memory deficits, as well as environmental cues, errorless learning, family training, and using lists. And you can see more about memory on pages 219 and 227. Self-awareness. How do we work with self-awareness? And how do we teach clients self-awareness? Self-awareness is knowledge of one's cognitive abilities and the ability to monitor one's performance. The ability to recognize and correct errors in behavior and performance. Sometimes we all need a little self-awareness, especially me sometimes. So how do we do that? Well, we use feedback and consistency, cueing for deficits, vanishing cues, videotaping works wonders, and you can look in Zoltan again on pages 245 and 248. Initiation. How do we get people to initiate? This can be a really big issue with your TBI patients. Also your younger children that you're working with in the schools. And it's what it is difficulty starting a task. So we can use incentives, external cues, and there's some other ideas in your Zoltan book on 250 and 251. Planning and organizing. How do we teach this? Especially if we don't even know how to do it ourselves, right? So that is the attainment of a goal through a series of steps that do not necessarily lead directly toward that goal. Notice in the pictures you've got the before and the after with the planning and organizing. So how do we do this? Well, we start with an outline. Then we teach the organizational strategies, planning ahead and self-verbalization strategies, organizing materials. And there's more information and suggestions on page 254 and 257. Problem solving. Similar to organizing, I would think. It's the integration of several cognitive skills, including attention, initiation, information, access, and feedback. These cognitive skills build upon each other. And how do we do that? Well, we use a step-by-step approach to teaching. We can use worksheets for problem solving. You can use chaining. You should be familiar with what chaining is. External cues. And more information is in Zoltan on 262 and 265. Decision making. It's a form of problem solving in which one chooses from several options. And Parente and Herman provide guidelines for decision making on page 266 in Zoltan. Please review this before class. Mental flexibility. The mental flexibility of the wise man permits him to keep an open mind and enables him to readjust himself whenever it becomes necessary for a change. It's the ability to initiate, stop, and change plans. Participate in various activities, occupation-based tabletop activities that require frequent mental shifts. That's a good way to work with someone on mental flexibility. And there's more information on page 270 and 271. And this concludes the I'm sorry, this concludes the PowerPoint and the lecture for cognitive dysfunction. If you have any questions, you feel free to email me, or you can ask things in class. I hope that you come to class with questions. And here are some of the references that I used to produce this PowerPoint, and I look forward to seeing you in class.